Okay, yeah, a lot of people are here. All right, guys, so let's get started. So high yield health policy, so you can spend your time doing other stuff. There's things that pre-meds are so infatuated with, like organ donation. And they'll spend a day researching organ donation for their interviews. And I'm just like, yo, I've never been asked this in my life. I don't know why this matters. That's what I keep saying, guys. It's like, you're not asked about these deep biomedical ethics, like dilemmas. You're not. It's about communication and hot topics. But I'm here to give you a review of 20 very high yield. I mean, most of them are high yield. Some of them are just there. If they're high yield, then I underline them. If they're not, and people are just infatuated with them, then I just kind of give it to you. So you can quench your knowledge thirst, okay? So let's get started, okay? Organ donation. What should you know about this? You should know that some countries are on an opt-out model, some countries are on an opt-in model. US and Canada are on an opt-in model, so you're not an organ donor by default. You have to opt into being an organ donor. Other countries, you're an organ donor by default, but you can opt out. So there's benefits to that, especially in terms of addressing the organ shortage, right? And you can look up wait times for like a kidney transplant, a liver transplant, lung transplant, heart transplant. You can look up wait times, and it helps when you're in an opt-out model because people are by default. It's like, you got to convince someone to do something. People are just, they don't really care to change it. So whether they start off opted in or out, it has a big impact on addressing your shortage. Some countries have a marketplace for organs, so you can talk about, if you want to talk about that. It's kind of a crazy place to go. And I'm saying talk about that. I've never been asked about organ donation. Again, I'm just giving you the guys, like, if it's not underlined, I don't think it's high yield. It's just to quench your satisfaction for these topics. But yeah, there's potential for exploitation. But again, what if like you're in such poverty that this is like the only way, through donating your organ, you can lift yourself out of poverty and so on and so forth. Living donors and considerations of autonomy. So imagine that, if it's like a family member, well, are you really making a decision because you want to do it? Or do you feel like guilty or compelled, right? So there's a question of autonomy. Are you making a decision independent of external influences when you just donate an organ? Okay, so climate change next. So this is a pretty cool hot topic. What are the effects of medicine? I mean, there's tons of medical waste created all the time. So look, you can look into stuff like sustainable hospitals, understand its relation to Indigenous health, perhaps. For instance, a lot of Indigenous communities identify strongly with their nature. So if you have a wildfire or something of that sort, it's really going to affect, at a minimum, their mental health, but much more because, I mean, if you have polluted air and so on, it's just gonna affect your health, period, in a very direct manner, in fact. Okay, so environment and identity, especially with relation to the indigenous populations. Synthetic biology, this is kind of a crazy one. You guys can look it up, but it's basically you can engineer bacteria and so on to break down plastics. And it's a technology that's up and coming, but it's been up and coming for a long time, to the point where it's like, yo, why isn't this technology a thing yet? So I don't know, maybe you guys can make it a thing. But yeah, these bacteria have existed for a long time. You can engineer them to break down plastics and stuff. Okay, AI in healthcare. Risk of bias. This is what everybody is infatuated with studying, is like risk of bias. Me, I come from a computer science background. I've interned at Microsoft, okay? Am I saying that to flex? No, I'm saying that because when you come from a computer science background, you think of AI in a different way than like, oh, let me just see what CBT Health has to say about AI in healthcare. Well, it's going to say the same thing over and over again, the risk of bias. You should mention the risk of bias argument. Are you guys familiar with this? Just drop in the chat, yes or no. If one person says no, I'm going to explain it, okay? Okay, Ali said, all right. Sorry, I don't need to single out Ali. The risk of bias discussion is that if you have an AI model, the way these things work, it's just statistics. You give some input data, and then you show it like the output of what it should predict. And it learns, okay? Like at a very high level, it learns, okay? And it does that through modifying like statistical weights and these matrix multiplications and so on and so forth. Okay, I didn't explain it yet. Here, let me get to the explanation. The thing is, if you are making like a diagnostic AI, right, to maybe look at EKGs, ETGs, right, so those like those graphs that are relevant to your heart and ECG. If you train an AI, or like maybe on like risk factors for a certain disease, if you only, for example, put in patients who are white, or only patients who are Asian, or only women, or only men, that model can't be used very well on other populations. You see what I mean? It's a biased model. Okay, so, and a big thing is, well, we have, for example, as a percentage of our population, Black individuals are pretty small as a percentage of our population. So our AI models can perhaps not generalize well to serving Black patients, because maybe 40% of the people they've been trained on are of Asian descent. So, or like most of them have been women or men. You know what I mean? Like there's just, you got to make sure the data that you use to train your AI is very diverse and representative of a lot of different types of people with different comorbid conditions. Hamza, yes, it's going to be recorded. At the end, we'll show you how to access the recording, okay? So comorbid conditions means like diabetes, dementia, Alzheimer's, hypertension, things like this, okay? These are comorbidities. You have to make sure, if you're going to train AI and you're going to trust it to work in like a clinical setting, it has to have a very diverse set of input data from a very diverse set of people, okay? Is that clear to everybody? Put in the chat, like if it's not clear, just ask me again at the end, okay? Yes or no, is it clear? But here, okay, so this is what most people focus on. Obviously, it's very pressing, especially in terms of like hot topics, and disparities, and you don't want to perpetuate disparities and so on and so forth. But no one else talks about the other stuff. So using natural language processing in analyzing electronic health records. So I'm at the Mayo Clinic, right? I go to medical school at the Mayo Clinic. We've already started deploying in the test phase at the Mayo Clinic the use of LLMs, like it could be GPT, it might not be, I don't know, Chat GPT, but the use of LLMs in just like doing chart reviews. So if you've ever done chart review research, you know how boring that is. You got to read through everybody, all the files in a certain patient just to find some data. Well, now you can use like, an AI to read it, or, make some sort of, take some insights or pull some insights or so on and so forth. Okay. Most people, I'd say 80% of people talk about this. Maybe 40% of people will talk about that. But then there's even crazier stuff you could talk about, okay? So data security. Last year in Toronto, a hospital was basically paralyzed because these cyber hackers encrypted everything and just kind of paralyzed their systems, and they demanded a ransom in terms of like Bitcoin, okay? So if you're going to keep using AI and increasing digital the digital connectivity of your hospital, well, now you're more prone to attacks, and you can pull on some very real examples from what's happened in Toronto. Okay, cyber war and genomes. I mean, that's some crazy tangent you could go on. You could, I wouldn't necessarily, but you could. I mean, you could. With the rise of AI in healthcare, AI can be used to, like I said, cause security issues. And there's an interesting topic, because like I came from a computer science realm, I know about this, but quantum computing will, when it reaches like a little more maturity, it can break encryption. So imagine you use all this like encrypted, yeah, AB, yeah, you're right. You're encrypting all your medical data, right? So when you send data to a server, like to a website, you guys know how it says HTTPS, like HTTPS, I'm putting in the chat. The S stands for secure. It means that your connection to that website is encrypted. But the thing is, the most popular methods for encryption, quantum computers are thought, they can break that. So imagine some foreign adversary, okay, is just intercepting all the data that you're sending to your hospital, or that the AI in the hospital is using, and like back and forth between GPT. Oh, it's encrypted data. Okay, doesn't matter if someone can intercept it, because even if they see it, it doesn't make any sense. Well, once we reach quantum supremacy, you can actually unencrypt all that. So that's a pretty scary thought. I don't mean to give you guys nightmares, but you can tell there's a lot of stuff to talk about for AI in healthcare, okay? Not just the risk of bias argument. Okay, next, privatization of healthcare, healthcare worker shortage, definitely talk about that, because this is thought to be a solution to that, okay? Long backlog of elective surgeries. I mean, stuff like cataract and hip surgeries. This is what they're saying they want to do in Ontario, right? So in Ontario, we already have private, like family medical doctors. So they're saying, okay, maybe we should move some more stuff into the private realm to help speed up the backlog of surgeries, okay? A lot of people are very polarized on this, and because they're polarized, they don't learn the facts, okay? Like the deep facts, for example, they're like, oh, well, they're going to charge like some crazy money. As a private, to my understanding, as a private like family doctor, whatever you do, you can't charge OHIP more than what a hospital, like a public hospital would. The rates are standardized. You can't, even if you don't accept OHIP, you can't charge more than what OHIP would reimburse. Okay, that's my understanding of things. So once you understand that, it's not like, okay, well, they're gonna just make some crazy prices, like they're gonna charge like $1 million, right? And then they're gonna move doctors away from the public system because now they can charge $1 million for like a hip surgery. Well, no, they can only charge the OHIP standardized rate, but the other they like charging for like more convenience and luxury stuff. I know that, what is it? There's like Cleveland Clinic in Toronto. So this is, I'm pretty sure, a private hospital, right? Cleveland Clinic. So Cleveland Clinic is #2 hospital in the world, or it could be #3. Mayo Clinic is #1, okay? So Cleveland is #2 or 3, and they have a branch in Toronto. I'm pretty sure they offer a lot of private services, but again, the price you pay, it's not going to be more than what OHIP sets the rate as, okay? Guys, I hope you understand, like I did all this research to drop on you guys, so you're not tripping, like, oh, I need to research like a million things. I'm giving you the knowledge right now so you can spend your time improving and getting better, okay? Yeah, okay, so private companies, so this could lead to more investment in the healthcare system, but again, on the other end, it's like, oh, well, you're gonna pull doctors away from the public health system. Is this gonna create a two-tier healthcare system? Could it even worsen backlogs for people who can't afford to pay out of pocket, right? So there's a lot of considerations there. And then you can make comparisons to the United States, right? With what the United States is doing. Or like what other provinces are doing, okay? And I'm gonna just use this to quickly highlight this. If you guys ever checked out thebrightdoctor.com, we have over 13,000 users of our website across US and Canada, and we make question banks on MMI, panel interviews, and we have a lot of mini question banks on things like health policy. So we go over a lot of, you could look at US health policy, you could look at other provinces, and we have like questions and answers, expert answers from medical students to a lot of questions in these realms that you guys can check out, okay? Homelessness. Look into complex housing initiatives. Understand what these are, because these are like real-time solutions that are being proposed to address the homelessness crisis. Okay, so complex housing, yeah, look that up. I'm not gonna bore you guys with that, but the way you could be asked about homelessness is like either like solution-based thinking, or you have a patient who is, homeless, or and they come in, and then you got to think about maybe a communication style, what kind of questions you want to ask them, what kind of risk factors they'd be subject to for certain diseases or certain just social things that they might lack, right? They might lack their immunizations, for example, right? So that's like the kind of ways you could be asked about the homelessness crisis. Okay, you guys can read that. Vaccine ethics. So, what do you think we did right, wrong, COVID-19 response, hesitancy. I've been asked a lot of questions. It doesn't matter if it was during the COVID thing or not, but I mean, I interviewed, yeah, during COVID, but it could be it's probably not going to be a COVID question anymore, but if you're asking sort of vaccine thing, it'll probably be like either a communication question where it's like, oh, you're talking to a mother who comes in, or the patient's like a little kid, and the mother doesn't want to give like a measles shot, right? The MMR, because they read online that it can increase your system, like it can increase autism. Okay, so then you got to talk to them. So that's like the context you'd see that in. The truck protest, I mean, yeah, I was asked about this in one of my interviews, the truck protest. It's kind of far removed, but it just goes to show that like this is like when I was interviewing. So know the hot topics today, like tariffs and stuff. Yeah, invoking the emergency hour, is that the right thing to do or not? You know, have an opinion on that. Mistrust in medicine. So if you're, this could relate to like the indigenous populations because they were subject to residential schools. They were subject to forced sterilizations. Imagine if you've been injected with a needle and it made you sterile. Like, do you have a right to not trust in the medical system anymore? And okay, I'm going to talk to you guys about how to talk about these communication style questions in terms of like getting someone to stop smoking, getting someone to like stop vaping, because I've been asked these, or like convincing them to get a vaccine. I've been asked these. I'm going to show you a framework for that, okay? Towards the end. Just make sure I don't forget. Scope expansion. So I talked to you guys about this, like, and if you were in the last two sessions. This is basically you have non-physicians doing more and more work that physicians usually do. For example, pharmacists can prescribe 11 different medications in Ontario as of last year. So you don't have to go to your family doctor. That frees up your family doctor from patients, right? So there's a family doctor shortage, there's a primary care shortage. This is thought to be a solution to that is, hey, let's give more and more autonomy to pharmacists, nurse practitioners, physician assistants, in terms of like basic things like, prescribing antihistamines or whatever, to free up our family doctors because there's very few of them. Okay, should you have accelerated pathways for internationally trained physicians? This is thought of as another solution. We have all these internationally trained physicians, and it's like, there was like a joke. I mean, I don't know if it's a racist joke, I have no clue. But it's like, oh, if you want to get healthcare in Canada, just take like a taxi or something. And it's sad because you have all these internationally trained doctors who can't practice, right? Because of like the pathways they need to go through residency. It's like, oh well, and I've had that. Like I've been in like the most random spot, and there's like a normal worker there, and it turned out the guy was like a surgeon back in his home country or her home country, right? It's crazy. So do you think this is right? Because on one end, like Canada's very multicultural and diverse, right? So imagine like sound like a Persian dude, right? My family, when they go to a doctor, they want to see a Persian doctor, okay? I mean, there's value in that, right? But then you could be like, oh, well, someone who trained internationally, maybe they weren't subject to the same rigors, and so on and so forth, right? Because obviously there's differences. So do you think, yeah, anyways, have an opinion on that is what I'm saying. Mental health, yeah, there's a current crisis, especially among youth, connections to technology and social media use, body image discussions, yeah, change in family arrangements. There's a lot of stuff these days, divorce, change in family arrangements, a lot of social media craziness going on, filters. I mean, that's like the most simple thing to talk about. And yeah, you can give a background on this, talk about, preventive care programs and solutions. You can talk about telehealth, accessing telehealth. You can talk about cool things like, for example, Instagram. If it senses like you're sending like a lot of weird messages about like suicide or something, it'll give you like a pop-up like, hey, how are you feeling? If you feel like you want to hurt yourself, call this number. Okay, I saw that online. Elderly population and mental health, yeah, huge. There's a very, very large elderly population in Canada. It's increasing very fast. And They have mental health issues. I mean, they're very lonely too, right? Because like, us young people, we're too busy for them, right? So there's that. So could telehealth help? Could like AI chatbots help? Think about that. Should we let the big tech companies, peer into our phones and messages and read them, like I just said, Instagram does? Role of medication, so those, SSRIs, SNRIs, selective serotonin reuptake inhibitors, selective norepinephrine. Guys, can you tell I just took my board exams? Anyways, access to therapy, yeah. So, how can people access therapy? Should the government subsidize therapy? Yeah. Yeah, guys, I just took my board exam. That's why my knowledge of some things is very astute right now. Medical assistance in dying. Okay, sorry, this should not be highlighted. This is something I don't find high yield at all. I've never been asked about this, but people are infatuated with this. Guys, euthanasia, you should know, you should have a very developed opinion on euthanasia. Okay, so I would recommend you guys simply look up the Canadian law on this, all right? Especially the changes that were made in 2021. Because that predisposes, that leads to the slippery slope argument, because they're thinking of expanding it to, mental health conditions, or perhaps children with some very, very dire, lethal conditions. So should we keep expanding it more and more and more? That's a question. Another one is, if you have an elderly person, an elderly patient, maybe they're paying for these hospice homes or these residential homes, these what are they called? These senior care living facilities. They're so expensive, guys. They're so expensive. Or maybe they're just being a burden. They feel like they're being a burden on their family. So they might be like, oh, well, okay, I guess I'll just die. I don't want to put a burden on my family. Maybe they don't actually want to die because the option is there. Are they really making a choice because they want to, or because of some external influences? Okay, so think about that. Indigenous care. All right, so I talked about this extensively in the past 2 sessions. Colonization, understand, the historical context of our Indigenous tribes in Canada in terms of colonization. Have some opinions on rural health, understand, it's far. They might have to get on a helicopter to get to their nearest trauma center. Cultural competency, be aware of how they really take a holistic approach to healthcare, right? Whether it's like the shaman. So a lot of times, you might want to treat someone, but you can't use like allopathic, really medical terms. Maybe you want to bring a community leader into the hospital to kind of be a delegate, to be a liaison and mediate conversations, so you can explain health in terms of what it means to them, okay? And understand their goals. I mean, goal-oriented care. This is a huge topic, right? What are your goals, right? Maybe they don't want you to do some invasive surgery. Maybe they feel like the best thing is XYZ, okay? I mean, that's in general anything, right? Especially with elderly patients, a lot of times they don't want like potentially curative, very invasive surgeries because they're usually risky because they're frail. So they might just elect to just have like comfort care, go to hospice. Okay, so communication of scientific knowledge. I've been asked in virtually every single interview ever. MMI, panel, doesn't matter. Some sort of question about either misinformation, battling misinformation, or how to disseminate some sort of knowledge to other people, or dealing with like explaining something to somebody. Okay, it's like it could be explaining some scientific topic. I've had that once, guys. I think it was a Canadian interview. It's like explains some scientific topic to a 3-year-old. Okay, what was the question? It was explained. I think explained like DNA or like genes or something. It was like some genetic thing, right? I fully forgot, guys. I fully forgot. But I made an analogy with Lego bricks, right? Like your DNA is like Lego bricks, and they can be different colors. So my interviewer loved that. Okay, my interviewer loved that. I'm just saying, be ready to communicate things to different populations, whether it's like, and understand. Okay, if they don't speak your language, you can use an interpreter, right? Yeah, public health, huge. Modes of communication. I can't say which school. I remember which school, but there was a question where it's like, you want to get some public health message out, to a wide population. So how are you going to do that? And yeah, you kind of got to discuss about, okay, young people, most people say, okay, young people, I'll advertise social media, old people, I'll put in the newspaper. Wow, that was so amazing, right? Of an answer? No, everybody's saying that. But I remember my friend gave a very good answer because he told me after what he said. He said something like, well, in Canada, we have a very diverse population. We speak a lot of languages, and we use different social media platforms, right? A lot of Russian people use, I think it's called VK. A lot of, I think, is in China, they use WeChat. Okay, there's like different social networks. It's crazy, right? So it's like, oh, I could tailor to their social networks. I could make sure that I go to different community centers, right? There's like Filipino community center. I mean, there's so many different community centers, different languages, Jewish community centers, Indian community centers, and so on and so forth. And I would just, in different languages, disseminate information across different platforms, so on and so forth. And they gave a very strong answer like that. Okay, misinformation. Yeah, have some approach on battling misinformation. I mean, there's like a million things depending on how deep in the level of censorship or free speech or down that rabbit hole you want to go. I mean, I'll leave you guys to make an opinion on that yourselves. And lastly, this is like a really good word to use, evidence-based medicine. You want to make sure that you deliver evidence-based insights, that you can distill evidence-based knowledge, okay, to people. And maybe have a source, a hub for evidence-based knowledge and so on, so people don't get their information from WhatsApp, okay? Aging population. Okay, I talked about this a little bit. So tax system, understand that we have a smaller and smaller workforce. Paying taxes into a social service, into a for social programs that are feeding and serving a growing elderly population. So that's a problem, right? Because these people have comorbidities. They're living longer than ever before, right? They're living longer than ever before with diabetes, with Parkinson's, with hypertension. So they need more and more and more medications and surgeries and whatnot. But you don't have, our population is like, the pyramid is not like expanding at the bottom. So you have less people who are working and paying taxes, less tax money to help our social services. Okay, wealth transfer. I mean, yeah, medical system dying. I talked about that. Resource allocation. There's like some anti-aging technologies. You could look that up briefly. Okay. Global health. Okay, so by the way, a lot of these. So I just want to point you guys back to the website. So if you go to our, we have over 300 questions with expert answers from medical students. Let's click on medicine/MMI, reset progress to see all of them. And then let's just go to, for example, policy hot topics. I mean, yeah, I'm going to uncheck ethics and behavioral and personal. Let's just do scientific or policy. Test mode, create test, begin. Let's just do a different one. Okay. What are the most important developments in medicine in the past few decades, in your opinion? Okay. So you're going to have time to think. You can really practice your timing. Begin. I'm going to record my answer to this. I'm going to click finish. This is our website, by the way, barrydoctor.com. And we give answers, real-time research answers from medical students to these questions, along with tips to go beyond, red flags to avoid. And I just wanted to say, because you guys all saw the mini question banks, right? I'm gonna click skip. Like, what are the pros and cons of legalizing medical cannabis consumption? We don't have a cannabis mini bank, but we have questions within our main question bank. Okay, key healthcare challenges present in developing countries, different types of contraception. How is climate change? See, we don't have a climate change mini bank, but we have this answer. Save your video, send it to your friends, guys review. But we have answers to all these questions. So just because, like, I just want to make sure, just because you don't see aging population mini bank here, doesn't mean there's actually a lot of aging population. I think there's at least like one or two in the medical school interview question bank. That's over 100 questions here. And then between all of these, the specific provincial mini banks, like health policy, there's other more focused questions. But everything you see here, almost everything is in this as well. Okay, next, global health, okay? Infectious diseases, COVID. I'm gonna call this lower yield, except for COVID. You might be asked something about COVID, we just went over that. At least I think we did. If we didn't, let me know, because I presented 2 presentations before this. What do you think the role of more wealthy countries is, guys? Do you think that more wealthy countries should be distributing vaccines or not? Because, some people are like, oh, well, Canada's giving vaccines to this country, that country, but we don't have enough vaccines for ourselves, right? Or like the US, for example, right? With Pfizer vaccines, should the US keep them all for themselves until they're all vaccinated and then ship them out? Or should there be some sort of distribution plan for countries that do not make their own vaccines? Different types of aid, okay? There's vaccinations, there's antivirals. I mean, it doesn't even have to be COVID, guys. This doesn't have to be COVID. It could be with malaria. What is the role of more wealthy countries in your opinion, right? There's influence of politics, guys. So this is pretty huge. I wouldn't get into any fiery, like, real-time politics, but you can mention something like in Venezuela when the US sent, it was like a bunch of aid, like medical supplies and food and stuff, in like 2 big containers to Venezuela. The Venezuelan government set it on fire. It was like a political symbol, okay? So yeah, should you prioritize your own citizens? Because ultimately, okay, I'm going to vaccinate everybody in Toronto, right? And I'm not going to give vaccines to any other city. Well, what happens in Guelph is going to matter in Toronto because that person from Guelph is going to pull up to Toronto. And this happens on a global scale, right? So, okay, we're not going to send our vaccines to Asia, but hey, there is like travel back and forth. And, so what is the solution? School and tuition, guys. This is such a cool topic. Okay, such a cool topic. I'm going to say this is high yield, not because you're going to be asked this, because this concept way of thinking is really cool, okay, in terms of applying to a lot of different types of questions. So there's a question, should medical school tuition be free? Should it be taxpayer funded? What do you guys think? You could talk about how several schools in the US are free, but they're not taxpayer funded. They're not, okay? It's like billionaires giving philanthropic donations. What about other types of schools? Okay, are we going to just make medical school free and not law school? Why? Why should that be a thing, right? What about trade schools? Should they be free? Like, why is medical school the only one that's taxpayer funded? Why does someone who not went to medical school have to pay taxes and subsidize their healthcare? By the way, guys, your medical school tuition is already subsidized by the Canadian or provincial governments. I mean, it's not like full price. But here's where it gets interesting, okay? This strategy is thought to be a solution to the primary care shortage. Because people say, oh, well, the reason a lot of people go into these crazy specialties is because they have a lot of debt. So if you have no debt, because your medical school tuition was free, or if you have minimal debt, then you don't have to try to gun for, what is it, like ortho, right? Or like plastic surgery or like general surgery. General surgery is like considered more relaxed to get into, but you can, do pediatrics, you can do something your heart desires, or you can go into primary care is the idea there, because you're not in some crazy debt. Does that make sense? Like, drop in the chat if I just made sense right there. Someone drop in the chat if I did or did not make sense. Okay, I made sense. Okay. Yeah, relevance of grades. So this is huge because more and more you're seeing schools not look at MCAT or not look at your CASPER. I mean, that's not bad. Not look at your MCAT or not look at your activities. Like McMaster doesn't look at your activities, right? So there's like a discussion of privilege or something, like you weren't able to do it, maybe you had to work during school or whatnot. Standardized tests versus subjective. So that's another thing, right? Should you use things like Casper, AMC Preview, or do you prefer MCAT, or neither? Okay, what's the role of an interview? So this is very interesting, guys. This is like something I learned about very recently. Ever since transitioning from in-person interviews to online, certain medical schools found out that more people of higher BMI are being accepted, right? So where people being, like where the interviewer is being, what's the word? Discriminatory or prejudiced towards individuals who were overweight, right? Before, because like, oh, ever since we went online, there's more people who are, classified as high BMI being accepted, right? So there's a lot of interesting topics in this realm. Implicit bias is the word, right? Anyways, next, LGBTQ population, so respect, dignity, and understanding, using their preferred pronouns, making sure they're in a safe and welcoming environment, okay? Use of training in a work environment. So, and they have specific risk factors and their own healthcare concerns. Like, you can talk about HIV prophylaxis, their mental health concerns, talk about, basically, this is more like communication, showing that, hey, you can talk to people who may not be of your, you might not be in that population, but you can still work with them and make sure that they get a very excellent healthcare experience from you. And intersectionality, you guys can look that word up. It's basically when certain different like prejudices, I'm probably butchering this definition, but just like pile up, okay? So just look up this word. It's a good one to know. Okay, aging population. I went over this. Am I tripping, guys? I'm not tripping. I think I went over this. I think this is a duplicate. All right, and lastly, just a few last ones. International medical graduates. So yeah, retraining, residency spots. Because people are like, oh, why are there Canadian medical graduates going unmatched in the residency match, but there's internationals matching, right? So it's not fair to us. Okay, so you have an opinion on that if you think it's fair or not, so on and so forth. Okay, I talked about this. Housing, yeah, the housing price, I think I talked about this. Oh, you could talk about vacancy tax, international investments. I think the Canadian housing market's a little slow right now. I think it is. Yeah, doctor shortage. But here's a cool thing, guys, right? Imagine you didn't brush up on the doctor shortage, okay? Imagine you just didn't, for some reason, read about this. But hey, you read about IMGs, mid-level providers, digital health, and so on. Boom, you don't, like, you see how I just didn't study about this, like, specifically, but I have a lot of things to talk about, and you're not even gonna end up talking about all of them. You don't have time. So guys, like, the more and more you study, the better things get. So for joining, I'll tell you how to get the slides. All you got to do is sign up for a free account on thebrightdoctor.com, and make sure, if you already have an account, just make sure you log in tonight. If you log in tonight, we're going to send the slides to your email, and you're going to have access to the webinar. It's going to be posted within 2 or 3 days to the past webinar section. This is all free, okay? So there's over 300 questions with expert answers. I also want to show you guys this, because for your interviews, I know we talk about ethics and hot topics, but you might be asked personal questions, which, I mean, you usually are, even if it's MMI. And what we have, right, as of this year, let me just finish. We have purchased many, many more answers from medical students who were accepted. So for personal style questions, you can have several answers from different medical students, and you can see their perspectives, okay? So what's the biggest challenge you overcome? Begin, answer, finish. Begin, answer. And see, we have 3 different answers. We have 3 different answers from different medical students that you can look at, tips to go beyond, red flags to avoid. We're going to give you a credit for use with either a monthly or yearly, whatever you want, with our website very soon. Okay, so you can use our question banks. There's 10 free questions on MMI if you want to check it out. And we also have admissioncareer.com. A lot of people, they like paying for medical students to like practice with them, especially once they got the knowledge down, to help with their like communication and making sure they're answering questions well. We have a lot of medical students from Canada, so UBC, U of T, McMaster, and so on and so forth. And we let you, there's several benefits to our website because we have a competitor in the space. We let you pay in Canadian dollars. We don't charge you tax, and we don't have a booking fee. There's no session booking fee every time. So we're very competitive in those 3 ways. So you can just click CAD, and then it'll just show you the Canadian price. And if you sign up by tonight and you check out, and you just log in by tonight, we're going to give you a $10 Canadian voucher to use for your first consultation if you want to use that, okay? So that's admission fee. You can just access it when you log in and click Marketplace, okay? Are there any questions for me? Guys, was this helpful? Like, tell me, like, was this a good review? Put in the chat, like, what do you guys think? Was this a good review? Very helpful, AB says. Like, be honest, like, because I was trying to put together a lot of the topics that either people are tripping about or are just very high yield into one place. And we're gonna send you the slide decks, okay? Just sign up. We're gonna send you the slide decks, so you guys don't have to like waste like so much time studying, like just getting, oh, organ donation, like, you know, just like trying to get the basics of things, so you can go learn more and more. You know, whether it's more specific health policy. And I said this in the last two, but if someone just joined like only for this session, if you use this and you study Ontario health policy, also check out other provinces, because if you're asked like a health policy question, you could talk, oh, by the way, this is how British Columbia does it. And I would also check out the American Health Policy Question Bank, because privatization of healthcare is a huge topic in Canada, and you can definitely pull in some American health policy knowledge. Like, I wouldn't spend like a lot of time on this, I just skim it, but you could get some cool like insight to add to your answers if you do American health policy. Okay, Savithru says, got to see different perspectives I didn't even think to talk about. Yeah, I'm really happy that's the case, Savithru. Thanks for telling me that. Emma says, how do you suggest we approach those communicate? Oh, I forgot to tell you guys about that. I'm sorry. Okay, I'm gonna pull that up. I have a slide deck for this, okay? Guys, I have a slide deck for this. It's 3 slides. It's 3 slides. It's 3 slides. I'm wondering if administrators already put them in. Okay, yeah, you did. Awesome. So let me just refresh this. Mr. Administrator, are the slides in here or no? Okay, I don't see them. All right, I'm gonna pull them up, guys. Give me 2 minutes. I'm gonna pull them up. No, these slides are crazy, guys. It's 3 slides and they're crazy. Okay, so this was from our medical school interview summit. We had like 5 guest speakers, including me, or 6, including me. I forget. So imagine you're asked, your friend Elliot expresses concern with getting vaccines, citing information that they saw online. Consequently, they might not be able to perform a clinical rotation at external sites. Okay, guys, you could be asked this on MMI, you could be asked on a panel. It doesn't matter, because on MMI it could be like, how was your approach scenario? In a panel, could be the same question, or you could be talking to someone like who's pretending to be Elliot. Okay, like a trained, standardized patient. There's a framework for this stuff, and it's called the stages of change. Okay, guys, this framework. It's not a random Google image. This is tested in the USMLE, the American Medical School Board exams, step 1, step 2, step 3. And this is like, I was tested on this on my exam, okay? And what's the other thing? I'm pretty sure Canadians too. Like, I don't know. I'm out of the Canadian system now, so I don't know. Move the individual to, you want to move the individual to the next stage of change, okay? So you want to move them from pre-contemplation to contemplation. So I'll show you what this means, okay? For example, quitting smoking. I once had what was it called? I once had a patient who I was supposed to like take care of, just like to take a history as part of my first year of medical school. I just had to take a history, right? And as part of the history, I found out, hey, well, they have kids and they also smoke. So whatever, it wasn't it wasn't their chief complaint or what they presented for. So once I got the chief complaint, done, or my supervising person, the attending, helped me deal with it. He's like, oh, go and do some motivational interviewing on the patient's smoking habits. And I was like, damn, what the hell is that? What's motivational interviewing? Like, is this like David Goggins? Like, get up in the morning? Like, what are you talking about? And they pointed me at this. So I read this, and I learned like what to say. And basically, I asked the patients, hey, you told me you smoke 1 pack a day. Have you ever thought about smoking? Okay, and the patient was like, no, not really. I don't want to quit right now. Honestly, I've tried before, but I don't want to do it. I'm just not in the position in my life. Okay. So where are they, guys? Tell me right now. Are they pre-contemplation, contemplation? Just tell me. Tell them, put in the chat. Where are they? What stage are they at? Come on, guys. They're at pre-contemplation, okay? So the thing you gotta say, it's like a research, like this is evidence-based medicine, guys, is to kind of stir up some awareness or like some like dissonance in them, right? And here's what I said. I asked them, well, why do you think it would be important to quit smoking? I asked them that, and that's what you got to ask to get them from here to here. And the patient said, "Oh, okay, well, I have a family history of lung cancer and like XYZ." And that's it. That's it. Like, and then that was it. Like, we talked, and then we talked for like two more sentences, and that was about it. I'm not trying to take them from 1 to 6, okay? Although in your interviews, in my experience, they will be quick to move, okay? They will be quick to move to here, to like determination, okay? You might want to push them to here because you have like 3 minutes, and they're kind of like standardized patients that are kind of, told, okay, like let them ask you some questions first, and then when they kind of warm you up, they'll be able to change or whatever. But just to really hit this point home, this is a UWorld question, okay, guys? It's a UWorld question when I was studying for Step 1 USMLE. This is literally, I'm telling you, on US board exams. So I'm sorry if I give anybody PTSD with UWorld, but okay, let's read this quickly. A 52-year-old man comes to the office for a routine follow-up appointment. The patient has a history of well-controlled hypertension and hyperlipidemia. He has a 35-year history of smoking, okay? Big smoker. Family history for lung cancer and mother, okay? This is kind of sounding like that patient, right? His father died following a stroke at age 65, okay? When asked about whether he has considered quitting, the patient replies he's not ready to stop smoking. This was literally the same thing as what I experienced. It was just like very similar. He says, I know I probably should, but I'm too stressed at work to give up my cigarettes right now. To be honest, I'm probably smoking closer to a pack a day. Which of the following is the most appropriate response to the patient? And look, I suggest that you consider how your health may improve if you stop smoking. It's crazy, right? You think this would be like a decent thing to say. Like, look, 1% of people chose this. I understand that you're under a lot of stress, but you're capable of more than what you think. Here's the thing. Yeah, 17%. The right answer was, what do you worry will happen if you quit smoking? What about if you don't? This is exactly what I said for that patient, remember? And this was the right answer. I don't know why the hell I didn't pick that. Obviously, I goofed up, but I should learn to trust myself. But yeah, see, I'm not capping, guys. This is like some real research stuff that's tested on board exams of how you approach these scenarios. So it could be like vaccine hesitancy. It could be a lot of different communication things could use this. Not all of them, but a good chunk of them could use this framework. And you notice, like, this is a fine sentence to say. I understand you're under stress. But it's like you want to get at what this framework is like telling you to do, okay? Guys, you really took me on a tangent there, but I'm really happy I presented this to you because I think this is really cool. Yeah, there's another point I make. I mean, I can talk about it if you want. But guys, I'm gonna wish you all a very good night. I'll get to Simran's question last. Simran asks, question above. In a panel interview, how do you know how long your response should be? So yeah, I wouldn't ramble for too long, guys, because like usually the first question or two in a panel interview, especially at certain schools, it's like I can't say the schools, it's like NDA stuff, but it's like, oh, why do you want to, tell me about yourself. Why do you want to be a doctor? So I have like a decently long answer to that, okay, which is like 3 minutes. But then unless they ask me some crazy stuff, like I'm not talking for that long. I'm giving like a minute answer tops, 90 seconds. It'll just make sense because you don't want to ramble. Because you want them to ask like more things. If you miss something, you want them to ask a follow-up question about it, and so on and so forth. All right, guys. Lastly, yeah, to access the recordings, all you got to do is make a free account on thebrightdoctor.com. It'll be under past webinars. Make a free account, and we'll be sending you. All you got to do is log in. If you have an account already, just log in by tonight, and we'll be sending you a credit code for use on our question banks and on the marketplace if you want to speak with medical students, okay? All right. My pleasure, Simran. My pleasure, Sophie, Samantha. My pleasure, Emma. I wish everybody the very, very best. I hope we delivered a lot of good value to you guys tonight.